All right. Well, good morning, everyone. My name is Michael Fukasawa Schmitz, and I'm happy to have the opportunity to meet with you today to talk about implementing CBTI. When I was invited to do this presentation, the original title of the talk was instituting CBTI, and we had a little dialogue about what the content of the presentation should be about. As we will see in the objectives, what I chose to do is really talk about it from the clinical standpoint of implementing the core strategies of CBTI. I'm sure most of you, if not all of you, have been introduced to CBTI concepts. But I also wanted to add some aspects of implementation, thinking about CBT as an intervention within health systems. So, and that is comes from the bias of my background. I'm currently the director of the Insomnia and Behavioral Sleep Medicine program of the M Health Fairview Health System in Minneapolis, Minnesota. That's a complicated name. It's essentially the largest Minneapolis Twin Cities-based healthcare system, combining the University of Minnesota, its clinics, and the Fairview Health System. And there I work with our sleep disorders program, where we have 6 multi-service, multi-specialty clinics throughout the Twin Cities area. So I'm going to switch to the full screen now and move on with the presentation. Okay, I'm assuming now that you've got the full screen of my presentation. I do not have any conflicts of interest or disclosure.
We cannot see your presentation. We can't okay. See the presentation.
Okay. So we're going to end the show, and what I didn't do is okay. Here we go. How about that? Share.
There we go.
There we
okay.
go. Okay.
Now, yeah, go to full screen from beginning. And, slideshow. There we go.
Okay, now I've got folks on the side, so okay. All right, I'm more familiar with using Microsoft Teams, so this I do use this with relatives and families, though. So anyway, the housekeeping for today is that on the Zoom platform, you will notice that questions can be entered in the chat feature at any time during the presentation. I've been asked to wait till the end of the presentation to answer questions. That's usually not my style of presentation, but I think it'll flow better for the purposes of our virtual meeting today. This webinar is being recorded, and at the end of the presentation, we'll pull up the questions and try to get to as many of them as we can during our time together. This webinar is also going to be recorded in and will be on the website in 2 to 3 weeks after the presentation. So learning objectives for today is basically, I think it's very important as sleep fellows to get a good understanding of who is a candidate for CBTI. We'll identify some of the core interventions of CBTI and their rationale. We'll identify some of the common challenges in implementing the core interventions, and understand key opportunities and challenges in implementing CBTI in sleep programs and health systems. One of the goals that I've had in my career serving as the president of the Society of Behavioral Sleep Medicine, and later the new certification board called the Board of Behavioral Sleep Medicine, is the goal of disseminating CBTI more broadly, and getting more people trained and certified to be able to administer the intervention. Also allowing for a greater pool of professionals, including nurses, psychologists, social workers, physicians, and others to become qualified in administering CBTI. Well, this is obvious to you folks, but the prevalence of insomnia is great. We estimate that at least 40 to 70 million Americans experience intermittent or chronic insomnia. Some surveys say up to half the population in any given year experience intermittent insomnia. Chronic insomnia, however, is estimated to be between 9 and 12%, and interestingly, across the globe, this range, this percentage is fairly stable. I think great importance is that only about 5 to 25% of people with insomnia actually seek some kind of treatment. It's treated primarily in primary care centers and much less so in sleep disorder clinics. We see that women are twice as likely to develop chronic insomnia and are at greater risk. Insomnia, it seems, has a great impact on health and a number of different types of outcomes. Several very good studies have shown that there's increased healthcare utilization associated with people also reporting chronic insomnia. We see increased levels of work absenteeism in particular. It is well established that onset of insomnia is a predictor of a first episode of depression. More recent health-related cardiovascular data demonstrates an increased risk for hypertension with a sleep duration of less than 6 hours. I'm sure you're familiar with this model, but Art Spielman several decades ago developed a pretty elegant model of how insomnia may develop along differing types of predispositions, precipitating factors, and perpetuating factors. So in this model, the basic assumption is that every one of us has a threshold for insomnia or disrupted sleep, as well as the potential to go on to develop chronic insomnia if the right factors coalesce and come together. So in this model, we envision that individuals will be below the threshold, and then onset is determined by a precipitating factor. This model suggests that there are differing predisposing factors that place people at greater risk and, if you will, place them closer to the line of threshold for developing insomnia. We think certain biological traits may be at play, although not clear exactly which ones. They have been broadly referred to in the literature as a tendency towards hyperarousal. Spectral analysis of EEG suggests that individuals with insomnia may have relatively more active or faster EEG activity. Psychological traits have been studied, and we don't have a lot of definitive data on that. There was, pardon me, I cannot recall the citation on this, but the trait is of perfectionism, tends to link towards a predisposition for insomnia. And social factors play a role, we think, in the development of a predisposition for insomnia. Other predispositions may be co-occurring health issues that develop well before the onset of insomnia. We think predispositions related to diabetes, possibly some neurological conditions predispose individuals for first onset of insomnia. So a precipitant can be a number of things, and even when people come in and seek behavioral treatment for insomnia, the precipitant can often be something that's not behavioral or psychological at all. The acute onset of medical illness, and the stress related to it, the onset of psychiatric illness such as depression, panic disorder, etc., and stressful life events are some of the most common precipitating factors that trigger an acute and then developing into an extended bout of insomnia. What's key, we think, in terms of this model of treating insomnia behaviorally is that we know clearly that if we treat and stabilize precipitating factors and try to control even for predisposing factors, that insomnia often perpetuates well after its onset for months and years. And in this model, we think that behavioral factors and reactions and response to the insomnia itself serve to maintain the insomnia over time. An example of some of these are excessive time in bed, frequent napping that reduces homeostatic sleep drive, and behavioral conditioning that occurs over time. So this is Charles Morin's model of insomnia. It just takes a similar but different take, and I like this model because it really shows the dynamic interplay between different types of behavior, but it adds how cognition affects arousal. So with insomnia, we know that for the most part, there's an increase of emotional, at times cognitive and physiological arousal, not only anticipating or at bedtime, but during the night as well. This experience of poor sleep and arousal can lead to dysfunctional thoughts, increased worry, oversleep loss, rumination, and in particular, fear about the consequences of the insomnia. This in turn can lead to maladaptive habits. I have many of my patients who who respond to protect themselves against sleep-related anxiety by spending more time in bed, calling into work and saying that they can't come in, or daytime napping if they can. As individuals notice predictable things like irritability or some fatigue, they also begin to become more anxious and aware of perceived performance impairments, cognitive impairments, even though data around neuropsychological functioning with insomnia is inconclusive. Patients tend to focus a great deal on experienced or perceived deficits, which then serves to increase emotional and psychological activation and arousal. So when we come to the mythology of insomnia, there's been a big shift with the International Classification of Sleep Disorders, second edition manual and the third edition. In the ICSD-2, the world was framed as individuals having primary insomnia and also described as psychophysiologic insomnia. And this group was estimated to be about 20 to 25% of patients. In my clinical practice, I just keep wondering where those patients are, because they're not that common in a specialty care clinic. As I work in helping to train primary care therapists, we see this incidence, it seems to be much greater. The second form of insomnia is essentially was described as a secondary insomnia, thought to be due directly from the effects of a medical or psychiatric condition. So these were insomnia caused by or secondary to a primary illness. in the ICSD-2, there also was a myriad of subtypes, as you may be familiar with, psychophysiological insomnia, adjustment insomnia, idiopathic insomnia, that being as insomnia of long-standing duration, often emerging in childhood, paradoxical insomnia, inadequate sleep hygiene, and so on. The problem, though, is that we still don't have a clearly defined pathophysiology for insomnia, and that the characteristics of psychophysiologic insomnia, as it's commonly referred to, or primary insomnia, occur across most, if not all, of the subtypes and do not reliably identify it. And a review of the literature in the development of the ICSD-3 made note of this, and a decision was made that, or a determination was made that the subtypes are not reliable, and because they do not predict treatment response, and that's importantly a note that was important in the consideration of developing the nomenclature for insomnia in the ICSD. These subtypes in the ICSD-2 were collapsed. The last thing that factored in as evidence for why the subtyping needed to be changed in ICSD-2 was that a growing and primary intervention, CBTI, was shown to be effective across a number of these subtypes of insomnia, previously considered to be secondary insomnia. So it sort of begged the question, what are we really looking at when we describe insomnia? And do we get to any level of diagnostic clarification that would really direct or alter treatment? If you really have different subtype disorders, you would think that it would direct you to very clear types of differentiated treatment. And in the case of insomnia, it typically did not. So what the ICSD-3 settled on was a simple scheme involving the primary disorder of chronic insomnia disorder, and then lasting 3 months or more, and then a short-term insomnia disorder of less than 3 months. This nosology recognizes essentially the bidirectional relationship between insomnia and co-occurring medical problems. Let's move on to talking a little bit about CBTI effectiveness, and I'm sure you're aware of this, but CBTI overall has been studied fairly extensively in comparison to benzodiazepine and non-benzodiazepine medications, and has been shown to have superior long-term effectiveness. It definitely is not as quick of an intervention and does not result in quick response time as medications, but its durability is superior. There have been some models in which it's proposed that CBTI be combined with short-term use of sedative hypnotics to allow individuals to get quick treatment response followed by, or in concurrence with behavioral treatment for long-term durability of treatment for insomnia. In 2016, the American College of Physicians came out and recommended CBTI as the first-line treatment for chronic insomnia. And the American Academy of Sleep Medicine, in its practice parameters, has outlined it with some specificity CBTI and different specific interventions such as stimulus control, sleep restriction, relaxation therapy as standard or recommended treatments. Recent research in the last 5 to 10 years has turned its eye to internet CBTI, and the results are good. It compares nearly as effective to in-person CBTI, particularly with longer treatment duration of internet programming. One of the caveats that is important is that Internet CBTI in particular had a pretty high dropout rate. And it seems that when CBTI is augmented with clinical support by trained individuals, that the effect size is better and truly becomes more comparable to in person. And now, of course, during the pandemic, the description of what is in person has changed, and we're in a new world of starting to look at comparing virtually administered CBTI with in-office CBTI. So, and this is a strain that I'm sure many of you in your fellowship have heard, is that despite the effectiveness of CBTI, there is clearly limited access to trained CBTI providers. Currently across the United States, there is less than 300 individuals who have a certification in behavioral sleep medicine, first initially in the early 2000s by the American Board of Sleep Medicine, and then now later the Diplomate in Behavioral Sleep Medicine. There have been organizations such as the University of Pennsylvania that have made great efforts to train individuals to learn CBTI intervention skills. The VA, under the leadership of individuals such as Colleen Carney and Rachel Mamber, have done a great deal of work to try to train and disseminate CBTI within the Veterans Administration population of patients. However, it is estimated that treatment dropout rates are fairly significant, and they're estimated to be between about 10 to 40% in clinical settings. The most interesting thing I find, though, is that we don't really have reliable predictors of who will respond to treatment. And we certainly don't know, when we look at cognitive behavioral therapy for insomnia and its four major components, which are often variably combined, sometimes in different ways, we don't know in which patients which type of intervention is the one that results in the most significant response. So all in all, we have a kind of global response, and CBTI is an umbrella term for a set of techniques that are fairly well controlled for, though in practice, the intervention is manifest in a number of different ways. Bice and his group have what is called brief behavioral therapy for insomnia. There's individuals who apply CBTI for 8 to even 10 sessions. There is group CBTI. In our setting, we use a briefer model of CBTI, usually between 2 to 4 sessions, although we have flexibility to extend out to 6 sessions if needed to maximize response. Now, one of the things I think is important to spend a little bit of time as we get to the interventions, because you just don't want to deliver the intervention without really knowing who, as best we can, will be appropriate for it. And one marker we're discovering may give us some very good indication about whether a CBTI, whether a person is going to be a candidate for CBTI. And this is the information coming out lately about people with insomnia and objective short sleep. So we're now, at least in research and more in clinical settings, referring to objective short sleep duration as that being of less than 6 hours. And there's data to suggest that it poses significantly greater health risks than people with insomnia of normal sleep duration. So the finding that we have found most interesting and are now starting to apply in our clinical implementation of CBTI is that we have data that indicates that this group of objective short sleepers also has a blunted and suboptimal response to CBTI. And this is something actually before these data started emerging, I observed clinically that when people came up in and they would be reporting on their sleep diaries that they had 5.5 hours of sleep versus a person who came in with an average time in bed of 8 or 9, even 10 hours, but they were reporting average sleep of 6.5 or 7 hours, that the response to those short sleepers tended to be less robust. Now, need to be clear here that this is based on objective sleep data, and most of the patients I saw had the advantage of overnight PSG and in many cases actigraphy. We do know that actigraphy, along with sleep diary data, tends to underestimate total sleep time by about an hour. And people with insomnia and their self-report on sleep diaries tend to have a degree of sleep state misperception and tend to underreport total sleep time when compared to normal sleepers. So this graph just shows the blunted response. The two groups are baseline of individuals with objective sleep of less than 6 hours and a baseline of those with normal sleep. And at 6 months follow-up, the mean wake after sleep onset in the group with normal sleep time, we had looked at the group, about 90% of this group, I believe it was about 150 individuals, had a mean wake after sleep onset of 31 minutes or less. Well, the blunted, sleepers who got less than 6 hours had very little change in their wake after sleep onset. The insomnia symptom questionnaire was administered, and the response there as well was minimal in terms of sleep symptoms compared to the individuals that slept more than 6 hours. They had a fairly robust, actually dramatic response in the reduction of their insomnia symptoms. And lastly, sleep efficiency overall changed more for normal sleepers who got more than 6 hours than those with less than 6 hours of sleep. So when you're seeing patients, just considering that this is an emerging phenotype of the objective less than 6 hours of sleep, and it may down the road represent the need to consider different treatment options. It may also suggest that we need to look at whether this group may benefit from a combination of pharmacologic treatment with CBTI or even pharmacologic treatment alone. So at this juncture, I want to introduce a patient just as a reference as I introduce some of the strategies for CBTI. This is a patient that I saw fairly recently. I'll call her Joyce. She's a 69-year-old female. Her prior medical history includes hypertension, hypercholesterolemia, degenerative disc disease. She had a BMI of 31. Her medications at the time I saw her were atorvastatin, lisinopril, ibuprofen, taken PRN for pain. Her labs were normal, including a ferritin that we ran. I think her ferritin was 125. Her primary reason for referral was fatigue and insomnia, mostly difficulty staying asleep on 4 years duration. Her Epworth was 6, and her insomnia severity index was in the severe range of 22. We did do overnight polysomnography where we recorded 502 minutes. Her AHI was within normal, 2.7, RDI was 6.4. Oxygen was basically fine. Average oxygen throughout the night was 95%. PLM index was 1.2, and overall sleep efficiency was decreased. She was observed sleeping laterally and supine, and all stages of sleep were captured and were relatively normal in terms of percent content. She did snore mildly. And so the medications she tried prior to coming to see us at the Sleep Center included diphenhydramine, which she said made her feel woozy, trazodone, which she said made her feel groggy, mirtazapine helped some, but then she felt it lost effectiveness and she didn't want to go up in the dose. She tried melatonin at bedtime and valerian root. She had not tried any of the Z drugs. So diagnoses offered at the time based off of this PSG was psychophysiologic insomnia combined with medical history and clinical evaluation. So keeping Joyce in mind as we move forward looking at the components of cognitive behavioral therapy, just want to do a brief overview and as we move on to the techniques surrounding them. So you've all heard of the stimulus control therapy. Its goal is to strengthen the bed and the bedroom as a cue for sleep. It also, as we will see the technique, may strengthen the circadian clock by its goal of getting up at the same time. By waiting to go to bed at night, it may also increase the homeostatic sleep drive as well. The stimulus control is the most well-established intervention and has the most research surrounding it. Sleep restriction therapy has also been studied a fair amount, and it basically involves restricting time in bed to increase sleep drive and to consolidate sleep. The strategy of relaxation training has been shown to be somewhat effective. Initially, it was thought to be mostly effective only for sleep initiation insomnia. More recent research suggests it may have an impact on reducing middle of the night awakenings as well. Sleep hygiene is a strategy that is used, as a part of the CBTI package. Used as an independent intervention, it's not been shown to be effective. In fact, sleep hygiene alone is often used as a control intervention in randomized control trials for CBTI. One can argue that it may reflect, pairing the intervention to the patient. If you get a relatively new onset of insomnia, acute within a few months, and there hasn't been a lot of conditioning or other perpetuating factors that have emerged, it may very well be that someone who started jazzing up on their caffeine and drinking 5 or 6 cups of coffee instead of their typical 1, that by addressing this sleep hygiene factor, you may in fact resolve their insomnia. So it's not to say that it's not useful or helpful in a component, but typically alone in the setting of chronic and longer term insomnia, it's typically not effective. The last area called cognitive restructuring or cognitive therapy addresses the maladaptive thoughts, beliefs, resulting in increased arousal, interfering with sleep. In recent years, more attention has been paid to this element of CBTI. And some of the reason for this is that there are many patients who come in to clinics and will indicate that they've tried a number of the measures that relate to stimulus control. They've read about sleep restriction, but they come into seeking help with a high degree of cognitive arousal and apprehension about their sleep. In our clinic, we refer to this as sleep-specific anxiety, as well as sleep effort. And so part of what cognitive restructuring does is address these thoughts with the goal of trying to reduce the monitoring and really, I call it sleep surveillance that patients do with insomnia. So one of the things that's really important in determining whether you want to use CBTI as an intervention is really looking at suitability, in terms of any intervention, whether it be medication or otherwise, matching the intervention to the patient as best can be achieved is important and essential. So I've just outlined here some of what I call suitability factors, and if you in your area have individuals who do CBTI and you make referrals to them, they will much appreciate in your evaluation assessing suitability when you make a referral. Suitability involves really a stable medical and mental health condition. That's not to say that diabetes, depression, anxiety, and other kinds of conditions are resolved necessarily or cured, if you will. But basically that individuals demonstrate a level of medical stability that they can, in your judgment, participate in and successfully achieve the elements of cognitive behavioral therapy as you, as an expert sleep provider, understand them. So, for example, a person who is in the middle of an intense or severe major depressive episode, who has difficulty getting out of bed and is very depressed, with very low motivation and drive, is probably not going to be a very good candidate for going to what we call in our clinic sleep boot camp. It may be that this individual needs to stabilize their depression. And what I often do with patients who have significant health issues is I ask them basically, this is what this method looks like. And we walk through whether they think they would be able to do these steps and the strategies that we recommend. A lot of times patients are provided education, instructional information, or even videos on how to do things. But if we haven't really looked at the suitability for this, we're certainly going to be looking in most cases at a treatment failure. The other thing to look at is whether a patient has sufficient insight and intact mental status to participate in CBTI. So basically, people need to kind of understand the principles and be able to follow the directions. Cognitive behavioral therapy relies on auditory and often written instructions. Now, a big caveat for here is that some of the best treatment of success I've had is individuals with developmental disorders. And so part of that comes with support of clinical staff in group homes and treatment settings where they reside, or parents who assist them in implementing the behavioral strategies, or making sure that the provider is well enough trained or will be able to work with individuals with developmental disabilities and frame the interventions in a way that meets their intellectual and developmental capacity. Lastly, I think something which is really hard to assess, I think, but it's basically, do you get a sense that the person is motivated for treatment? Oftentimes I will get referrals and they come in the form of, my primary care physician said I basically had to come here because he won't give me my medication. So that's a conversation we need to have, because so what would you like from me then? I can't make you motivated to do this, and I'm not a gatekeeper for medications. So really looking at what is the patient's motivation. And if I can get them to a place where they think, maybe this is an alternative, and they move to, let me just go through this hoop so I can go back and get my medications, we might have some avenue for success. Some patients will come in and they will say, well, my sleep doctor referred me here, but I've tried everything. So that's sometimes an opportunity for a conversation, but there it's really then important to hear patients out about what they've tried And oftentimes what you'll find is they have tried a few sleep hygiene things, or they've tried some of the recommendations on a 3 or 4 day basis and then abandoned them. Keep in mind also that there's a phenomenon which I call dependent, sedative dependent insomnia, in which oftentimes patients will come in having tried numerous different sedating agents, and they will have an experience where they work for a while and then they lose effectiveness. The patient becomes demoralized, or they become fearful about not sleeping. They go back to their prescriber, they get a new medication, and this all kind of builds a sense of loss of confidence in their ability to sleep. And it also unwittingly and unfortunately reduces their confidence that a behavioral intervention, after all the medication they've tried, would have any chance of being helpful. So when we look at cautions or contraindications for CBTI, these are some of the common ones. Untreated sleep disorders, I think, are important ones to consider. In our sleep program, we have developed an online screening tool called the Insomnia Health Questionnaire, where at the front end, we look at some of the possible co-occurring sleep disorders that can produce insomnia, and common ones are unidentified circadian rhythm disorders, particularly delayed sleep phase, unidentified restless legs, sleep maintenance issues in particular in patients with some of the other risk factors for sleep apnea give clues that this may be a condition at least contributing to the insomnia. Certainly unstable medical conditions and certain personality disorders, including borderline personality disorders, are often contraindications, or at least cautions. Again, looking at suitability, this doesn't exclude folks with these diagnoses along with bipolar disorder, but the importance is that these are treated and that the individuals are stable. With bipolar disorder, at least in our setting, we do not initiate sleep restriction, and we don't initiate sleep restriction in individuals with seizure disorder. Caution as well for individuals with acute PTSD. And it's very important that folks are in active treatment if they're doing CBTI with acute PTSD. Well, let's move into the interventions briefly, and then we'll talk a little bit about some of the challenges of implementing within a healthcare setting. So most all CBTI interventions include an element of sleep restriction therapy. For many providers, it's thought to be the strongest tool in our toolkit. And basically, the intervention involves cutting time in bed to the amount of time a patient perceives they sleep based on sleep diaries. And so in this intervention, you increase time in bed when sleep efficiency increases to greater than 90%. As I'm sure you all know, sleep efficiency is one's total sleep time divided by their time spent in bed. You would then decrease time in bed when sleep efficiency is less than 85% and keep the time in bed the same when the sleep efficiency is between 85 and 90%. In this method, we adjust the sleep schedule weekly until optimum sleep duration is achieved. Now, one of my patients called this intervention, and I love this, the sleep squeeze. And what he meant by this is what we're trying to do is reduce the time in bed to the actual amount of sleep with the goal of improving sleep consolidation, increasing homeostatic sleep drive overall, and with it, gauging the patient's daytime functioning, optimize the amount of sleep time once we've achieved at least relatively good overall sleep consolidation. One of the other elements with sleep restriction that's very important and similar to stimulus control therapy is that this also impacts circadian factors for sleep by establishing a consistent wake time. What's not in this intervention is the imperative to get out of bed and all the other sleep stimulus control recommendations. So in this example, this is Joyce, and this is a sleep diary, a real world sleep diary. And just want you to know, and you guys probably know already, that the sleep diaries don't look like the ones you often see at sleep conferences that are pretty and typed out, although people are getting much better at using Excel sheets. And we actually use an app, it's a publicly funded app called CBTI Coach that was part of the VA rollout. And that gives you a pretty slick digital display and graphs of estimated time in bed, estimated average sleep time, and sleep efficiency. We also accept Fitbit and other data. We love all data. We just take it with a grain of salt. So here what we're seeing is that this patient is spending an average of about 10.5 hours in bed. And you'll note that there's a fairly wide variety in sleep offset, 7 a.m., 9:30, 10. So we have a 2.5 hour or 3 hour variation in sleep offset. The time to bed, which interesting is what patients will focus on when they say that I'm doing everything I can and I'm doing good sleep hygiene. They will focus on the fact that they get to bed at every time at the same time. And we don't delegitimize that thinking, but we definitely do not emphasize it because we want to be able to promote stimulus control, which is going to bed when you feel sleepy. With sleep restriction and stimulus control therapy, our emphasis, for many reasons we want to reinforce, is getting up at the same time, and picking the best wake time is of the utmost importance. So in this sleep diary, we see that the patient is actually overall estimating it was 7.89 hours, and a normal amount of perceived sleep. So when we look at this, though it's not based on objective sleep data, it's subjective sleep data, based on the patient report, would definitely not fall in the short sleeper category. But when we look at the idea and the intervention of sleep restriction, it gives us an opportunity for intervention. We've got somebody with over 10.5 hours in bed at night, a 3 hour variation in sleep offset, and 7.8 hours of time in bed. So with this intervention, and what we did with Joyce is we used sleep restriction therapy, which I refer to differently as sleep consolidation therapy. It seems to go down better. A little sugar doesn't make the medicine go down, and we reduced her time in bed to 8 hours. One of the important things with sleep restriction therapy is to focus on the quality of sleep. So we wanted to have a reduced time in bed to improve the quality of their sleep. And she could readily admit that her sleep quality, as she said, was quote unquote crap. Our rationale then is to improve sleep quality, we need to increase her sleep drive. So we explained what that meant. And that's a concept that patients readily understand. We explain that a strong sleep drive reduces wakefulness, leading to better sleep. And then over time, as your sleep quality improves, your time in bed will slowly be increased if needed. So with Joyce, we reduced her time in bed, and I was looking for the actual sleep diary about her response over 3.5 weeks, and we were able to improve her sleep efficiency to 92%. We did not increase total sleep really at all, which I think was to be expected, given that she was reporting actually an adequate amount of sleep. But the results were her self-report was that she felt better. One of the big factors with Joyce was determining what was the best sleep window for her? And that's a very important factor to consider, and brings in, the consideration of circadian rhythm, timing of sleep in these interventions. Joyce didn't really endorse that she was a night owl. She certainly wasn't a lark, but she estimated that now that she's retired, that she felt that she could easily sleep till 7:30 or 8:30, but didn't want to be sleeping in later, and admitted that she usually just stayed in bed later because she was responding to a poor night's sleep. So in the end, we settled on a sleep schedule of midnight to 8 a.m., which worked well for her. So some of the challenges in sleep restriction therapy, as we just mentioned, was setting the best sleep window, keeping larks active and awake in the evening. So those who have an earlier bedtime and early rise time, keeping those folks awake till their prescribed time in bed is often difficult when you narrow that sleep window. Getting night owls to wind down in the evening is difficult, so you reduce the time in bed, but they may be on their computers and staying up. And so with sleep restriction therapy, we usually will implement, if not at the front end, at least the second session, some very clear sleep hygiene strategies to reduce physiologic arousal from lights and screen activity and that kind of thing. A big challenge for sleep restriction is getting people to get up in the morning at the same time, and we will run things through trials in their mind about what you plan on doing when you get up. What do you need to do to make sure you will get up? Do you have a timer on your coffee pot? Why don't you set your coffee to go off and be ready for you at 7 a.m.? And a big thing is that the collaborative process in doing sleep restriction is important, as well as telling patients about the cautions. You may be aware that in the Journal of Sleep that there was a very nice study, I think it was Krakow, that indicated that there are definitely potential side effects of sleep restriction therapy, and that patients need to be cautioned around possible excessive sleepiness, and that there could be mild cognitive and motor coordination changes related to reduced time in bed. So just letting people know that the biggest potential side effect of sleep restriction therapy is some sleepiness. So with stimulus control therapy, this is a method that can be done as a standalone therapy, but is usually combined with sleep restriction. These are the descriptions of the steps for stimulus control therapy we use in our center, but they're pretty standardized, across the literature and controlled trials. Basically, the goal of stimulus control therapy is to increase the bed as a cue for sleep. It's based on classical and to some degree operant conditioning. And with this, it's getting people to avoid going to bed until they feel sleepy. And people with insomnia will often say they don't know what sleepiness feels like. And we spend a little time talking about the difference between tiredness and fatigue. One of the things I will really focus on just somatically is sleepiness typically occurs and is experienced more in terms of facial experience, a heaviness in the eyes, droopiness in the eyes, difficulty holding neck up, versus tired. And my patients gave me these metaphors. Tiredness just feels like I have a few lead weights, that it's harder to move my body around. Insomniacs, people with insomnia, seem to be able to make this distinction because they'll often say that I'm perplexed why I feel so tired but can't fall asleep. The second intervention or a recommendation is you don't stay in bed unless you are sleeping. Variants of that, if you don't fall asleep within 20-30 minutes, or you wake up in the middle of the night and can't fall back asleep, you get out of bed. Number three, you get out of bed and go to another room and do something that is relaxing, pleasant, or neutral. Stimulus control emphasizes, as does sleep restriction, getting out of bed at the same time every day, and using the bed only for sleep and sex. So this gets at what patients sometimes understand as sleep hygiene, and in some respects it is, but really it's to realign the bed as a cue for sleep by getting cell phones, iPads, televisions, and anything non-sleep related out of the bedroom, and not using those devices or doing those activities in bed. And then lastly, to impact homeostatic sleep drive, we indicate to patients why they should avoid daytime napping, although we always put in a caveat around when daytime napping is an important compensatory strategy, you know, because we want it to be safety first. I realize that I am coming up to my time here, and I do want to have some time to answer questions. Today, my intention was to focus on the two major interventions for cognitive behavioral therapy. The final two interventions, which I outlined briefly, are cognitive restructuring and relaxation therapy. So two key takeaways from this are, with cognitive restructuring, a meta scheme you want to keep in mind is that individuals with insomnia tend to catastrophize their thinking with respect to feared consequences of insomnia. The other thing they tend to do is they tend to engage in safety behaviors to avoid the anxiety and the fear of not sleeping. So in some respects, addressing these cognitive beliefs and maladaptive assumptions, people can feel more resilient about their insomnia. And as one of my patients said, "Oh, you want me to face my bogeyman of sleep?" I said, "Yes, that's exactly right." And so we work with patients to identify some of these beliefs. In the end, we want people to avoid inordinate sleep effort. Some patients come up with a number of rituals and things they do to manage their sleep-specific anxiety and worry. There are a number of different strategies that can be used to help patients become less anxious and worried about their sleep. If people are highly anxious about sleep, this can be a barrier to actually implementing what is considered to be the two strongest components of the CBTI toolkit, sleep restriction and stimulus control. If you don't have the fear relatively controlled about the insomnia itself, patients may unwittingly sabotage for themselves their efforts to do the other interventions, which may be quite potent. And then lastly, with relaxation therapy, you know, my basic takeaway, or hopefully it's a clinically useful point in this, is that not all size fits all with relaxation therapy. And so for clinicians, part of the art of this is prescribing relaxation therapy that is acceptable to the patient. Not everybody wants to do an imagery rehearsal going down, you know, a pleasant creek to a riverside where the sun is shining every day. They don't have a strong capacity to do image-based relaxation therapy, but they may respond from progressive muscle relaxation. We tend to do more controlled breathing, talking with patients about different types of relaxation, or simply using activities that trigger relaxation response in and of themselves can be useful to help patients decrease arousal in the evening before bed. I think what I'm going to do right now is stop for some questions, and then we can talk, if anybody's interested, we can talk about some of what it looks like to implement CBTI in a system. So now what I have to do is I'm going to stop sharing, and you'll have access to the entire slideshow in a couple of weeks as well. So I'm going to go now to chat and see if there's any questions. First question here is, can individuals with BD and BPD participate in CBTI if stable? What are some of the concerning consequences that can occur for individuals with BPD who engage with CBTI? Well, that's a great question, and I referenced it earlier. So BD, I take it to mean as bipolar disorder, and BPD, borderline personality disorder. So yes, I have in clinical practice, and I think most individuals with expertise in behavioral sleep medicine see these folks in therapies. So with bipolar disorder, a lot I think rests on how stable they are in treatment, and that the CBTI not be undertaken if individuals are in acute hypomanic or manic phase. There is, I think, pretty good evidence that part of the dynamic with bipolar disorder is really that it can impact circadian rhythm, and that intrinsic to the disorder that sleep-wake cycles get disrupted. So when patients are stable and their depressive symptoms are managed sufficiently where they can implement stimulus control therapy in particular, and they can follow directions that in some cases people with bipolar disorder can have some level of auditory hallucinations. If there's any acute symptoms, those would be contraindications. But we typically would focus on stimulus control therapy for a broad range of individuals actually with mental health conditions that are active but stable. This allows patients to start the therapy with an average sleep window, usually about 8 hours, and then employing the stimulus control, focusing on reassociating the bed with sleep and intimacy, increasing it as a cue for sleep, while avoiding the pitfalls of sleep restriction, which could potentially trigger hypomanic or manic episode. So, and then the other cautions just are the ones that persons without bipolar disorder have. Are they motivated? Is the intervention credible to them? With borderline personality disorder, I see a number of folks who have this identified, as a condition, and some are active in standard of care treatment, including dialectical behavioral therapy. They're most often seeing a psychiatrist. And I've actually found that individuals who are actively in this really standard of care treatment can respond fairly well to CBTI, because the interventions for borderline personality disorder actually have a fair amount of structure to them. They're used to recording their thoughts. They do cognitive journals. They know some of the skills. But some of the maladaptive emotional responses would be things that you just need to keep in mind and need to be able to be aware of if you're doing the intervention. Sometimes individuals will respond with, have a dramatic response when they feel uncomfortable or anxious. There can be, you may need to redirect individuals and have them focus on the core. Sometimes there are boundary issues, and particularly I think that individuals who are treating people for sleep need to establish clear, collaborative relationship with the primary psychiatrist or psychologist, so that the treatment for sleep stays clear, and that other aspects of the mental health treatment doesn't bleed into the behavioral treatment for insomnia. The next question is, are there certain online CBTI resources you found to be more effective than others? So, you know, I don't want, it's hard to, you know, give, respond to that without, you know, saying, creating an endorsement, but there are a number of online resources, you know, and the landscape is changing also. You know, there once was a day when there were online resources called Shut-Eye and Sleepio. Sleepio now has become a program that's available only through corporate organizations and health insurers and not accessible individually. Shut-Eye closed its doors, but is reemerging with, I believe, another group that's working on actually an FDA online approved format. There are a number of universities that are offering online CBTI resources. Cleveland Clinic in particular has a program called Go to Sleep, which has some fairly good, they've got a great team with some good analytics behind it and some good data to support it. So these are, you know, several that I'm aware of. The publicly, you know, and university funded CBTI coach application, I think, is sound. And it's got some very, very good, pretty standardized information. It really is useful as an adjunct to virtual or in-person treatment, though. In our program, we use it as a way to use an online sleep diary. And also there are learning modules that we can use to individualize virtual or in-person care. There's also in my handout, I've got several other resources I've outlined as well. And you may want to contact the Society for Behavioral Sleep Medicine and their website, who has additional resources, period. Elizabeth James says, any thoughts about scheduling the sequence of appointments for CBTI when providing in a health system? Is the first session an overall SBSM evaluation or initiation of CBTI? What might scheduling staff tell patients expectations are aligned to service procedures? These are great questions. And from the questions, I'm thinking that this is an individual that is in the midst of a very active practice and providing these services to a wide-ranging audience. So, I can speak to our system and what we're doing. What we're finding is that the model we're using changes depending upon where the patient is seen. So, for example, in our tertiary sleep clinics where I see patients, we have a central scheduling and there's a dedicated scheduler. My services align with sleep providers and our sleep fellows' standardized sleep medicine evaluation. And then out of that, you know, when seen by me after a BSM evaluation, are offered CBTI in varying formats, and we're in the process of developing different formats. Currently, our services are all virtual, and then we partner with Cleveland Clinic for a sleep therapy assisted online CBTI tract as well. So our other arm of CBTI is an initiative in our health system to train our integrated behavioral health care providers. So these are individuals with master's or doctorate level training in psychology, clinical social work, who have an interest in sleep and who have an interest in insomnia and sleep. And with this group, we've done preliminary and ongoing CBTI training and offer weekly behavioral sleep case consultation. Here, the challenges often relate to how patients are seen in an active primary care setting. And the model of delivery of mental health services is not the same as we know across the country or in different settings. So mental health care uses the word integrated, but oftentimes it's co-located. So it may be where a psychologist or a master's in social work has an office space in a primary care or specialty care clinic, but their services are not really that integrated. So scheduling involves a physician maybe or maybe not having done a full evaluation of the sleep, making a referral to the provider who then goes to the front desk or calls the collaterally located psychologist to make an appointment, and then they do a diagnostic assessment. Typically, it's a mental health diagnostic assessment with the sleep component supported by our screening tools. Screening tools we have, as I referenced earlier, is we have I believe it's a 50-question insomnia health questionnaire, which our trainees in primary care have been trained to. It involves pre-screening with the Insomnia Severity Index, the stop bang, questions that relate to circadian rhythm disorders, Epworth Sleepiness Scale. We also use 5 questions to do preliminary assessment for motivation and interest in different modalities for treatment. But as getting back to the type of mental health therapy in our centers, many of our primary care are actually quite truly integrated behavioral health clinicians. So these are people who work elbow to elbow with primary care and will often see patients when they're coming in with an acute bout of maybe depression with insomnia, or insomnia might be their first complaint. So in this instance, we are working with our mental health providers to train them to how to assess the sleep complaint, use the screening tool to determine whether we need to get them to specialty care while we determine what they're appropriate for at the moment. So if we think it's more of an adjustment-related insomnia, the sessions may look different. So the clinician may be focusing on dealing with some of the adjustment-related reaction that they're going through, but may typically and usually elect to talk about how sleep is affected by adjustment reaction, and usually will employ stimulus control first. And part of that in the decision making, we found that we find that to make an appropriate intervention really for sleep restriction requires having we think some sleep diary information, and so we typically will want to help patients get going fairly quickly on an intervention that is achievable while we introduce them as well to completing of a sleep diary. And we then may introduce secondarily some sleep restriction dependent upon where they're at emotionally and with their adjustment reaction. But typically our model is that we introduce some sleep education after the initial assessment and do a combination of sleep restriction with stimulus control therapy. And the sleep restriction is to a level that is negotiated and tolerable for the patient. When the patient is, it's kind of a case conceptualization model, but if a patient is highly anxious about their sleep and worried, we will often introduce a cognitive restructuring model early on to get at any intense fear or worry about sleep and any barriers we see that might get in the way of implementing sleep restriction and stimulus control. That's a very long answer. I've gone on well beyond my time, and so I appreciate your attention, and I think we'll call it a close.